We are really excited for tonight's conversation and are just grateful for you to be here. So George, would you advance to the next slide, please? So Enlightened Soil Corp's mission is to empower farmers and land stewards in the effective and profitable implementation of a regenerative agriculture system. We as a team are committed to soil health, to education, and to profitability of farmers and land stewards. We're all guided by our connection to the earth and to the interdependence of life. We're constantly inspired by our farmers, by nature's design and human innovation. And we really believe in this ecological systems approach to sourcing food that is economical, nourishing for people and the planet. And that's really what we're going to dive into tonight with Dr. Taylor. So the product that we sell is EnSoil Algae. We grow live cell microalgae in facilities in South Carolina and in Florida. EnSoil Algae is a liquid concentration of living microalgae cells. The particular species we grow is called Chlorella vulgaris, which is a freshwater microalgae that exists in ecosystems all over the world. Growers are using EnSoil Algae for a variety of reasons, to activate soil biodiversity and functionality, to enhance stress adaptation, to improve crop production, to boost nutrient cycling and uptake, and to increase their return on investment. So EnSoil Algae is OMRI listed, and we support our growers with an educationally driven support team, very highly consultative, and we would love to talk with anyone that's interested in learning more after this webinar. So with that, I am honored to introduce Dr. George Taylor, our guest tonight. He is the founder of Enlightened Soil Corp. George's education began at the University of Illinois, where he worked in the dairy cow barns. He then attended medical school at their Chicago campus before his internal medicine and cardiology training at the Johns Hopkins Hospital. Subsequently, his career has included faculty positions at Johns Hopkins, at the University of Virginia, Southern Illinois University, and then for the last 25 years, the Medical University of South Carolina in Charleston. This is where he taught clinical cardiovascular medicine to students, medical residents, and cardiology trainees. He and a group of talented colleagues started this algae project on Johns Island in rural South Carolina. He's become interested in this food as medicine, food is medicine movement because it relates to his interest in inflammation and heart disease. So George, we're happy to have you here tonight. Perhaps you could start by describing how this all got started in 2018 and how it relates to food as medicine.
I'm going to dive right into the food as medicine discussion. It's become quite a movement, and I've become a believer. I'm going to start with my conclusion. My conclusion is that the phytochemicals, the antioxidant and anti-inflammatory compounds that are in nutrient-dense food, in fact, that's the definition of nutrient density, suppress oxidation and are anti-inflammatory, and that has a medicinal nutraceutical effect. A lot of people in the food as medicine movement talk about the food. That's where the emphasis usually is. Tonight, I'm going to talk about the medicine more so than the food. For those of you who are active in this movement, hearing the medicine part of it will give you some talking points. It'll be useful. The other thing is that in medicine as a rule, for us to believe that something works, that some treatment, for example, has an effect, we would like for there to be a plausible biological explanation for it, a mechanism of action that makes sense. And it turns out that that is the case in the food as medicine movement. This is a slide describing incidence of heart disease in the United States starting in 1900. I look at the incidence doubled over the next 50 years, and I started practicing medicine right about here. It was interesting in cardiovascular medicine. We realized we were constantly talking about the heart attack epidemic that we were in the middle of, and that's what I was involved in for the next going on 50 years. Causes of death in the United States, pretty much, and this is true, by the way, going back 100 years, 150 years, heart attack and stroke have always been the most common cause of death. And one reason that I'm talking about this and the is, well, there are two reasons. One is that it's very pertinent given the incidence of heart disease and stroke. But the other reason I'm talking about is what I've done. I can speak with some authority. The heart has these large arteries sitting on its surface. It's about the size of your hand, and the arteries are roughly the size of the veins on the back of your hand. They're the fuel lines to the heart muscle. They supply fuel and oxygen. If one of them closes off, the muscle downstream dies very quickly. That is what a heart attack is. And that muscle cannot be replaced. Once a person has lost so much muscle, the lights go out. The heart can no longer support life. So let's talk about how the atherosclerotic condition begins. This is really key. Everybody's heard of the bad cholesterol, LDL cholesterol, as opposed to the HDL cholesterol, which doesn't seem to be as bad in terms of being related to heart attack. LDL cholesterol, the bad cholesterol, becomes oxidized in the circulation. This is a cartoon of the arterial wall with the lining cells, the endothelium, the middle layer, and then there's an outer layer too. And oxidized LDL can penetrate the wall and initiate the inflammatory cascade. It involves recruiting a lot of different kinds of cells, white blood cells, including monocytes, T cells, lymphocytes. It also involves recruiting cells that are pre-existing in the arterial wall, and they're transformed by the inflammatory process. It's a complex interactive system, which we will not go into in great detail, but let me just point out that the upshot of it all is the formation of a lipid core. Here's a cross-sectional area up here. See the lipid core in the plaque. And then separating the lipid core from the bloodstream is a fibrous tissue cap, connective tissue, like scar tissue. This slide also points out that the inflammatory process releases cytokines, reactive oxygen species. Those of you who are in plant pathology or agronomy, you're used to hearing about cytokines and reactive oxygen species. We get the same thing in our bodies. And it turns out that they can be measured. Actually, they're not measured directly, but they are processed by the liver, producing compounds that are easy to measure. And the most common one that we measure is the C-reactive protein. And I will be referring to CRP in a couple of the subsequent slides. It's a very sensitive measure of inflammation. It doesn't tell you where the inflammation is from. It can be from anywhere in the body, but it's very sensitive. I had bronchitis after the first of the year, and my CRP had always been below 1, normal. I happened to see my doctor for blood work during this respiratory condition, and I got had his CRP measured. It was over 5, pretty high. Kind of shocking. And I wound up repeating it 4 weeks later, and it's back to under 1. I mean, anytime you get inflammation in the body, the CRP is going to be elevated. In terms of the heart, pretty much everyone who comes in with a heart attack has inflamed plaque, and pretty much everyone has an elevated CRP. If someone comes into the emergency room and has chest pain and you're not sure whether it's the heart or not, if the CRP is normal, it's probably not the heart. So the CRP, or inflammation, is a risk factor for heart attack and stroke, just like smoking, diabetes, family history, high blood pressure, cholesterol levels. When you're going to see your doctor for your annual physical, this is something you should add to your blood work in addition to getting a cholesterol measurement. The plaques that form can take a couple of different morphologies or appearances. On the left here is the cross section of a normal artery. The lumen, the blood column, an inner layer, a middle layer, and an outer layer. Let's look at the plaque on the far right, a so-called stable plaque. This plaque actually narrows the vessel by a lot. It commonly narrows the vessel by more than 70%, such that a person with a blockage just tight might get chest pain when they walk upstairs, angina. But the lipid core in this plaque is very small, and there are very few white cells. In many cases, the CRP will be normal. Most importantly, the cap separating the lipid core from the blood column is thick, and it looks stable, and it is. The risk of this person having a heart attack in the next year from this particular plaque is less than 3%. The middle picture is of an unstable, vulnerable plaque. And it tends not to, these tend not to narrow the vessel quite as much. In fact, most people who come in with a heart attack have a blockage that narrows the vessel by less than 40% or 50%, which I'll make a quick aside for those of you who are thinking about stress testing. Like, should I get a stress test to be sure I'm okay? Turns out it's not that useful, because a blockage has to narrow the vessel by more than 70% for a stress test to be positive. And these plaques that cause heart attack don't narrow the vessel by very much at all. So it's common for a person with a heart attack to say, geez, I had a stress test a month ago and they said I was okay. The test didn't pick up this kind of lesion. Now, this unstable plaque has a very big lipid core packed with red hot white cells, and the fibrous cap is thin and pretty fragile. Heart attack happens when this plaque, when this cap fractures and the contents of the lipid core are exposed to the bloodstream. That starts the blood clotting process. Blood clot forms very quickly, blocks the vessel off the rest of the way, and that is the genesis of heart attack and a stroke for that matter. These inflammatory cells make the CRP elevated, which leads us to the really obvious question: what causes plaque inflammation? Is the biology of heart attack. What causes plaque inflammation? And here's where the story gets quite interesting. It turns out that inflammation elsewhere in the body, I think of it as spilling over or causes vascular inflammation. And so infectious conditions of any type have been associated with a high risk of heart attack. And by the way, this literature is rich. I put this slide together 25 years ago. And there were 40 published studies at the time. When influenza or COVID goes through the community, there is a threefold or fourfold, that's what the odds ratio, 3.8 means 3.8 times normal incidence of heart attack. With COVID, the odds ratio is 4 times normal for people having heart attacks in the community. Bronchitis, the odds ratio is elevated twofold. Bacterial pneumonia, highly inflammatory, even higher. Staph sepsis, even higher. Urinary tract infection. Yes, the odds of having a heart attack during a urinary tract infection are increased threefold. Periodontal disease is an interesting one. The dentists often claim that they're preventing heart attacks, and they've got a point. Gum disease, the kind of gum disease that gives you loose teeth, not just bleeding when you brush your teeth, but real gum disease, periodontal disease, increases the risk of heart attack by, it almost doubles the risk of heart attack. Infectious illnesses, all of these, by the way, are associated with an elevated CRP. What about non-infectious illnesses? Yep, all of them do the same thing. Rheumatoid arthritis increases the risk of a fatal heart attack by 60% to 140%. That's what the odds ratio number means. Lupus, even higher, systemic lupus. Osteoarthritis raises the risk of heart attack on average by 30%. People who study osteoarthritis have come up with what they call a misery index. How bad are the symptoms? How much are you suffering? How much misery do you have? People who suffer the most with osteoarthritis have a high misery index, have a higher CRP, and they have a higher risk of heart attack. Somebody who takes the Tylenol once a week for his or her low back pain, or maybe once a month, yeah, the CRP is not going to be as high. The risk of heart attack is not as high. Asthma is an inflammatory condition of the airways, and the risk of heart attack is increased by 50% or even higher, or 150%. That's the odds ratio. The metabolic syndrome, something that everyone focuses on because it's so related to heart attack. It's abdominal obesity, type 2 diabetes, hypertension, okay, and elevated cholesterol levels. That's the metabolic syndrome. But it turns out that part of the risk of heart attack with metabolic syndrome has to do with belly fat cells producing inflammatory cytokines, which raise CRP and can provoke vascular inflammation. I'll tell you another aside type story. I became interested in this in the early 2000s because there was a commonly used arthritis medicine called Vioxx. Heck, half the population seemed to be taking it. And they did population studies and found that people who were taking Vioxx were having more heart attacks. I'll give you an example. The 10 Medicare database with 500,000 people. If people were taking the normal dose of Vioxx, the risk of heart attack was not high. But the people who were taking a double dose of Vioxx had a 20% increase in the risk of heart attack. And so pretty much everybody who had a heart attack while they were taking Vioxx wound up suing Merck. Merck hired a cadre of cardiologists to be expert witnesses and to try to figure out what's going on. And that, I was one of them. And my job was to look through the telephone book size stack of reprints, trying to figure out what was happening. And I ran across all of this information and figured it out. It turns out that association is not causation, and that's why population studies are seldom considered proof of anything. It turns out that who takes double dose of Vioxx? People with rheumatoid arthritis. And people with rheumatoid arthritis already have a 60% increase in the risk of heart attack. It was the arthritis. It was the rheumatoid arthritis and inflammation that was causing heart attack in these people. It was not the medicine. And that has since been proven. But to tell you the end of the story, Merck chickened out. They didn't want to have to go to a gazillion trials. And they settled a class action lawsuit for $3 billion and took the medicine off the market. We now have medicines that are exactly like Vioxx that do the same thing. And everyone understands that they do not increase the risk of heart attack. What about avoiding or suppressing systemic inflammation? Can that lower the risk of heart attack? Well, it turns out with rheumatoid arthritis, the risk of a heart attack is related to the elevation of the CRP, the amount of inflammation, not hypertension, smoking, diabetes, high cholesterol. Okay, it's related to the elevation amount of inflammation is reflected in the elevated CRP. And a number of studies have found that people who are on prednisone for their rheumatoid arthritis had fewer heart attacks. A similar thing was observed with asthma. I told you it's an inflammatory condition and associated with higher incidence of heart attack. It turns out that inhaled steroids, fluticasone, lower the risk and also lower the CRP. I mentioned that when the flu and COVID come through a community, there's a bump in the incidence of heart attacks in the next few months, except in one group. The people who got flu shots or COVID shots. Here's what the vaccines do. I'll give you the numbers. They reduce the chance of you getting the disease by 70%. If you happen to get the disease, you're unlikely to get the disease, it reduces the severity of the illness by 70%. You have a 70% lower chance of being of dying from the illness. So basically, getting the flu shot either protected you from getting it or lowered the level of inflammation. I'm going to let the plot thicken even more. You know, I've talked about risk of heart attack with acute inflammatory processes and inflammation in the near term, increasing your short-term risk of heart attack. But it turns out that inflammation early in life, you train your T-cell lymphocytes, your white cells, with these early inflammatory conditions, and you carry them with you the rest of your life, and that increases your risk of heart attack later on. The first signal of this came with birth cohort studies. Complicated slide, but let me just tell you what they did, going back and looking at data from the 1700s, 1800s. What they did is they looked at people who were born in years that were associated with a high infant or early childhood mortality. Give you an example. Let's say in 1880 and 1881, a lot of kids, there was a high infant mortality rate, high early childhood mortality rate, usually from the measles, by the way. Okay, which is what killed all the Native American Europeans came to this continent, the measles. But at any rate, so basically, if you were born in 1880 and you were exposed to the highly inflammatory condition, survived it. When you were 70 years old, you know, go fast forward 70 years, your risk of heart attack and stroke was higher at that age. You know, if you were born in 1880 in France, and some of the data are from 1880 in France, and you were drafted by Napoleon to be in his army, not 1880, 1780, in 1800, you're shorter. They collected those data. Yeah, you were shorter. And you had a higher risk of heart attack if you didn't get killed in the wars and made it to age 70. Which brings us to the slide I started with. This heart attack epidemic in the early and mid 20th century. I cut the slide off right here earlier because this is kind of where I started practicing medicine, remember? But if you keep watching the epidemic, wait a second, it's dying out. And by now, it's back down to the heart attack rate per 100,000 populations, back down to baseline. What happened? Epidemiologists have struggled with this. They've tried to say, well, you know, around this time, ready-made cigarettes became available, so more people smoked. Yeah, they look at it, but they can't make it work. The epidemiologists can't make it work. They say the obesity epidemic, you know, is might have had something to do with it. But wait a second, the obesity epidemic's out here, and yet the incidence of heart attack is still going down. All right, so it's not just the obesity epidemic. Hard time figuring this out, but I'll give you an explanation. Right here, in 1918, there was a worldwide flu epidemic, the Spanish flu, that killed 50 million people worldwide. The population that was most at risk with the Spanish flu were healthy young people in their 20s. And what would happen is that they would get the flu, become short of breath, go in the hospital, their chest x-rays would show white out of their lungs. And what had happened was that the intense inflammatory process injured the semi-permeable membrane between the air space and the blood space in the lungs. So all of a sudden, it became possible for fluid to cross that membrane and flood the airways. They wound up with terrible pulmonary edema, a condition called the adult respiratory distress syndrome. And They didn't have ventilator treatment. They basically went in and died in 2 days from ARDS, the adult respiratory distress syndrome. If you think about it, that's kind of what happened with COVID. What happens when people went in the hospital and wound up on ventilators? What happened was that they had the same intense inflammatory hit to the membrane separating the airway from the bloodstream, so that blood kind of poured across that membrane, flooding the lungs. Pulmonary edema, adult respiratory distress syndrome. However, now they were able to put people on ventilators and ventilate them with high positive pressure, which tended to force the fluid back toward the blood space out of the airways. And being on a ventilator for 3 or 4 weeks gave the lungs, that membrane, a chance to heal, to get better. That's what it did. It healed over time. And so so it functioned normally again, and they were able to come off the ventilator. Adult respiratory distress syndrome. Didn't have it in 1918. So what happened? These people in 1918 who didn't die, they had a huge inflammatory hit early in life, remember? Now they get older. Now they get to be 30, 40, 50 years old, 60 years old, 70 years old. They get into the heart attack years. And they have a much higher incidence of heart attack because of that inflammatory hit that they took when they were young. But then, of course, in the 1980s, 90s, 2000s, they all die of old age. They die out. So that the influence of the 1918 flu epidemic disappears from the population, and the incidence of heart attack comes back down to normal. Any inflammatory illness causing a high CRP, which is pretty much anything, will lead to vascular inflammation and can cause heart attack. And that can happen in the short term with an inflammatory condition, in less than a year. And it can happen with lifelong inflammation, the residual of lifelong inflammation. So why do we live longer than our ancestors? People have looked at a lot of different things, and they say, well, better nutrition. The epidemiologists can't make that work. I mean, all of a sudden we've got the obesity epidemic, yet we're still living longer. So, it turns out that our lifelong inflammatory burden is lower. One of the main things we do practicing medicine is chase inflammatory conditions. And if you think about it, you see it all the time. Your kids get strep throat, you get them on penicillin right away. All right. Don't want to be politically incorrect, but vaccination has changed everything. What about periodontal disease? Get better dental care, but also people don't get cavities anymore. Why? Fluorination, the water, it prevents cavities. So people, when I was starting in medicine back in the 1970s, early 70s, if a 50-year-old person came in, there was a better than 50-50 chance they were wearing dentures at age 50. We just don't see that anymore. People have better teeth. Even if they don't take care of them, they have better teeth. So basically, that's the answer. So how can food be medicine? I've talked about the role of inflammation. And you know what? Chronic illness, including cancer. I've not talked about cancer because I'm not expert in the field of cancer, but the cancer people tell a similar story with oxidation, messing up DNA and starting abnormal growth of cells and cancer. Okay, so it's chronic illnesses or oxidation and inflammation. So if there are antioxidants and anti-inflammatory agents in food, they can block the disease process. By the way, I mentioned things that blocked inflammation and worked. Talk again about heart attack. When the statin medicines, the cholesterol medicines like Lipitor and Crestor and all those came out, they did these huge population studies, and they found out, they were surprised to find that the more it made people not die as much from heart attack, okay? But they found out that effect was present at 4 to 6 weeks. 4 to 6 weeks of therapy, and at that point in time, death from heart attack was lower that early. And everybody scratched their heads because hard to imagine lowering cholesterol is going to have that kind of immediate effect. Well, then they discovered that the statin medicines lower CRP. They're vascular anti-inflammatory drugs, in addition to lowering cholesterol. To prove the inflammation hypothesis, there was a large study done using a drug that just blocks inflammation, not aimed at blood vessels or anything else. It just blocks the action of white cells to see if it would lower the rate of heart attack in high-risk people. It was a study of 10,000 people. They used a drug that's used in gout, which is called colchicine. And all colchicine does is it blocks the activity of white blood cells. That's how it blocks inflammation. And yes, indeed, when they enrolled these 10,000 people and treated half of them with colchicine and half with a sugar pill, yeah, CRP came down in the colchicine patients and they had fewer heart attacks. So yeah, anytime we can block inflammation, we're going to lower the rate of the most common illness that kills people in the United States and Western Europe, and that is atherosclerotic cardiovascular disease. We're getting signals now that there are foods that can do this, or things in foods that can do this, and they are the phytochemicals. There are organic compounds in food that stimulate plant growth, stimulate microbial growth in soil, called phytoplant hormones. Those are auxins, cytokinins, gibberellins. But we'll be kind of familiar with those. But it turns out that these micronutrients, the phytochemicals that include polyphenols, flavonoids, carotenoids, a few vitamins, okay? Polyphenols, there are 8,000 of these compounds that have been identified. And they've actually done studies with individual compounds that they've isolated. They've been, in animal studies, they've been found to have antioxidant effects or anti-inflammatory actions. And so a lot of the pioneers in the food as medicine movement have found that if you, I'm thinking of a paper by Montgomery, Bilkey, and Archuleta, published in 2021, where they looked at farms from around the country, and they looked at farms where the agricultural practices were engaged that increased the microbial content of soil and the biodiversity of the microbials. And they showed, with a few measurements, they call this a preliminary study. They said they showed increased phytochemical content. Okay. You know what they didn't show? And no one has, really. They did not show a health benefit. Well, you're saying, wait a second, if these are anti-inflammatory, they must be healthy. Or if you're doing organic and you take out pesticides, it's got to be healthy. And I agree, yeah. But there aren't any data measuring health outcomes that show that they're healthier. There are not any data that show me that if I eat health food from the health food store, organic food or whatever, that I'll live a week longer or jump an inch higher. That kind of health outcomes data is hard to come by, and especially hard to come by in humans. But we have recently gotten a signal from animals that may be the case. First, though, let me show you these oranges grown by Herb Young in North Georgia. On the right are mandarin oranges that he grew after many years of regenerative ag practices, including, by the way, addition of EnSoil algae to the growing process. And these pale-looking creatures over on the left-hand side were grown across the street. They're genetically the same plants, and they were grown with just synthetic chemical fertilizers. And Herb actually sent orange juice out and measured the phytochemicals. That's this nutrient column on the left, measuring flavonoids, carotenoids, some vitamins. Expensive test to do. This is the conventional ag column. It had some of these things, but not many. But if you look at the oranges, those bright oranges that I showed you in the previous slide, the content of the phytochemicals in them was much, much higher. Okay. Camille, you can turn the slides off if you would. But I just mentioned that we've got a signal now that
George, can you just press that? Can you just press that button that says stop sharing right there?
Stop sharing. Okay. Whenever there's a big computer problem in our company, I get called in to ask to solve it. On again. Am I still in the meeting?
Yeah, you're great.
Okay. 2 weeks ago, Brian Massard, a rancher from Montana, did a webinar that was absolutely fascinating. He showed, he raises Black Angus cattle. He feeds 7,000 to 10,000 cattle every winter. And he said that his cattle were healthier after he'd been treating his pasture with 2 applications of algae a year, and he had treated his hay with 3 applications of algae during the growing season. And he says his cattle that were eating algae-treated food were healthier. Okay, how are they healthier? Could you measure anything? This is what I'm talking about. Measurable health outcomes are hard to come by, but he had them. He said he has heifers that they impregnate with artificial insemination, and he had said that the failure rate of artificial insemination was much, much lower. Usually, I don't know, 15 to 20% of the cattle don't get pregnant. In the algae plant-fed cattle, that number was down to 8%. I'm told by people in the ranching industry that is a huge, huge effect. It's a huge economic effect. In addition, he said that his grass, his native grass, and that's what he's using, his native grass, is deficient in a lot of minerals. And so they've always had to put out mineral supplements. And he found that the cattle grazing on these pastures started ignoring the mineral supplements. He has reduced his mineral supplementation by 90%. Another measurable difference. And he also mentioned that his new calves were heavier. We've heard from other ranchers, cattlemen, that they're seeing that their cattle seem healthier, grazing on the algae-treated pasture. I tell people this story, and here's what they think. Here's the initial reaction is, okay, you feed the algae to the cattle, they're healthier. Algae has a lot of healthy stuff in it. It has the phytochemicals in it. It's got a lot of good stuff in it. No, that is not what Brian Massard did. This was not the result of him using live algae as a feed supplement or an additive. No. The grass he grew and the hay that he grew, that he fed to the cattle, made them healthier. Think about a human parallel. In that story, who would be the consumer? The cattle. Who would be the grocer? The supplier. The rancher. And we've heard that Mr. Massard is now he buys feed and grain and hay from local suppliers to feed this large herd of cattle. He is asking them to grow his feed supplies using the algae. And by the way, this was not a regenerative ag project. There was no cover cropping. There was no tilling. This is open pasture. He just put the algae down. And we've done soil testing showing that the microbial biomass and diversity is increased when you treat soil with the live algae biostimulant, just like it's increased when you do regenerative agriculture using no-till, cover cropping, etc. And algae, of course, can be a part of that as well. The biostimulant can. Okay, that's a pretty impressive signal. Anything else? Okay, and as a result of that, this year we're trying to collect as many crops as we can that have been grown with the algae when there is a control group that can be compared. So for comparison, and what we're doing is we're sending these crops out for measurement of phytochemical levels. The lab, it used to be terribly expensive. It's still expensive, but not as bad. And the lab will measure total phenol content, but it will also measure, we'll do what Herb Young did with his mandarin oranges. It'll give us a survey of 40 different phytochemicals and levels of those specific compounds. And we're looking to see whether or not it is consistent that use of the algae as a biostimulant stimulates the crop's phytochemical level. Montgomery, Bilkey, and Archuleta, and their really important study of regenerative versus contemporary or conventional ag and phytochemical levels, nutrient levels, or nutrient density. They said, which what a lot of the experts are agreeing with, is the biodiversity and the microbial biomass that puts the phytochemicals into plants and into their fruits. Okay, sure makes sense to me. And it turns out our soil testing using soil genomics and PLFA measurements, Haney testing, also shows that the algae will increase the same, have the same effect on soil. Any other signals? Yeah, I'll tell you one. There's a grower in Georgia who's testing strawberries. And in his strawberry, one of our research people, Meredith Garrigan, who runs a lot of this research program, was looking over the test plot and comparing it with the control plot. Has an acre of strawberries treated with the algae, an acre of strawberries, or 2 acres or 3 acres treated with conventional fertilizer. And she says the plants look great. They look more vigorous, and the berries look bigger and brighter. And I said, okay, did you taste them? She said, wow, yeah. What was the difference? Were they sweeter? No, it wasn't the sweetness. It was the kind of the vivid strawberry flavor popped out at you. I said, oh, it was kind of like the strawberryness of the strawberries was more impressive. She says, yeah, it's kind of like that. I had the opposite experience the same week. I was putting blueberries on my cereal that I bought from the grocery store. The berries were big and juicy looking, no blemishes. They looked fabulous. I could tell they were blueberries, and they had some sweetness, but I'll tell you, they were bland. It turns out that phytochemicals, the phytochemical compounds we've been talking about, are responsible for color and for taste. A number of ranchers have observed that when they have a half of a pasture treated with algae and the other half of the pasture not treated with algae, their cattle tend to congregate, preferentially graze on the algae treated pasture. Why is that? I think it's because there's more phytochemical in those plants. And so I say, why do they do that? And they say, well, they sense that it's healthier food. I'm sorry, I don't think the cattle are that smart. I think they eat that grass because it tastes better. And it turns out that taste is probably a very good measure, a very sophisticated measure of phytochemical content. We're going to be measuring it using expensive laboratory methods. But I'll tell you, I have a feeling that it's going to parallel differences in taste, and we're going to do some blind tastings at the same time to see if we can tease that out. But I'll make one last comment before we set the questions, and I'm going to make a prediction. I think, based on all of these data, and these are all preliminary data, we're going to know a lot more in 2 years. I think in 5 years or 10 years, when we go to the grocery store and want to know how healthy a health food is, we're going to see on the package or a plaque over the fruit bin, we're going to see a table that lists the phytochemical content of that fruit. That's what makes health food. And it's going to be measurable. And as time goes on, measuring it will be cheaper and cheaper and cheaper. And that is how we're going to basically define nutrient density, because nutrient density is about phytochemicals. Phytochemicals can be measured. And by the way, if you're not able to measure them, sneak a strawberry out and taste it. You'll find out just the taste test will be pretty good. Let's stop at that, and I will answer questions.
Awesome. Thank you, George. Frank in the chat wants to know about why we don't feed the algae to the animals directly. He says that they do in Australia and have scientific evidence to show significant differences.
Yeah, very good point. Very good question. And they do. In fact, I think that Brian Massard does use some algae feed supplements. They work. They have a lot of vitamins, minerals, phytochemicals. Yeah, it's pretty good. What we're growing, though, is we're using live algae as putting the live cells down in the soil where they release the phytohormones that stimulate plant growth and increase soil fertility. And they also probably release these phytochemicals that stimulate the microbials to make phytochemicals that take out by the plant. Live algae cells in fairly small numbers. Algae that's used as animal feed is dead algae. It's algae that has been processed, okay, and is grown in bulk and is being processed, but it's dead algae that's being used as food. Humans can get it too, by the way. You can go to the health food store and you can buy Chlorella vulgaris pills, okay? It is not live algae. It's algae that's been processed and is dead. So, but it's still, it's dead like your broccoli is dead when you buy it and cook it and eat it. All right. Yeah. It's still good, but it doesn't work as a biostimulant. It doesn't work as a biostimulant like EnSoil Algae does, because it's not living and continuously producing these growth promoting compounds. But a great question.
So Frank has now said in the chat, I just asked him a question, and you can unmute yourself, Frank, if you're there, but research shows 16% less feed intake for ruminants. The algae he's feeding is alive, that they're feeding to animals. I'm curious what kind of algae you're feeding. Oh, you're feeding live Chlorella vulgaris. Okay. Very interesting. Are you, I'm curious about the protocol there. How are you feeding it to the animals? Is it liquid?
Yeah, we'd love to talk to you about it. If you grow algae in one of these big photobioreactor tanks, or grow it on a pond and immediately put it on the food, yeah, I agree. The animals were eating live algae. If you are putting it in a bottle or a tank and shipping it, to another place for it to be used as food or processed as food, live algae doesn't live in the market. It dies out fairly quickly. And that's been the difference. That has been our trick, if you will. We figured out a way to keep algae alive in dark storage so that the live algae can be transported and used in a remote location. And it can be saved for use later on. It's got shelf life. But if you put live algae in the dark, as in a bottle and in a box, yeah, it's photosynthesis dependent. The cells die fairly quickly. We kind of figured out a way around that. So no doubt.
Frank, we'd love to connect with you.
Yeah.
I think Barry had his hand up. Barry, are you there? If anyone would like to unmute themselves and ask a question, please feel free.
Camille,
Okay, go for it.
Camille, I was going to throw out a comment here.
Great.
But I put my hand up instead, so I just typed it in. One of the questions I have, Dr. Taylor, is the phytochemical response due to that comes up through the soil, is that the increase in the carotenoids and the flavonoids?
That's what they're saying. That's what the experts are saying. Yeah, it looks like it's related to the microbials that live in the soil, which define fertility. Okay, soil microbials, and the soil microbial diversity is responsible for the phytochemical uptake and by plants, and that's what appears in the fruits. So yeah, that's what they are saying. And it happens with regen ag practices. We're thinking that it may happen with just the use of live algae. And the signal for that, Brian Massard's experience with his cattle.
Brian is wondering, what can you tell us about the metabolites expressed by the microalgae?
Metabolites expressed by the live algae? Well, we know that they make the phytohormones. We actually early on we sent algae out for mass spec analysis and found that the algae produces the full array of phytohormones, including auxin, cytokinins, gibberellins, salicylic acid, ethylene, jasmonic acid, all of these things. Yeah, the algae makes all of that, and those things all appear in the growth medium that the algae is growing in. Some people are using the growth medium as a biostimulant. Yeah, it works, but it's short acting. Putting the live cells down, the live cells continue to produce these things. Other metabolites, yeah, I mean the Chlorella vulgaris. I read the other day that Chlorella vulgaris is 60% protein by dry weight. If you dry it out and measure protein, 60%. There's a lot of fatty acid of the omega-3 type. Okay, there's a lot of healthy stuff in the algae, like there is in other plants.
So Francis is asking, does your algae consume bacteria besides being photosynthetic? And Frank has answered with rhizophagy to check out our work with Dr. James White. So the algae can be absorbed into the plant root as endophytes, Francis. And do you want to talk about rhizophagy at all first?
Well, yeah, it just happens. It was a big surprise. James White at Rutgers is the one who discovered this. He has these photomicrographs of algae in the rhizosphere near root hairs, plant root hairs, filled with bacteria, like the algae's ingested the bacteria. Then he has pictures of the thing halfway across the root hair membrane, half in and half out. And then he has pictures of the bacteria-filled algae in the root hair. And then he has pictures of that look like the algae is exploded, releasing the bacteria. It sounds bad, doesn't it? Releasing bacteria, but these are endophytic bacteria that are important for plant growth and are beneficial for plant growth. So, yeah, it turns out that the not only can the algae be endophytic, but in the process, it looks like it transports other endophytes into the root hairs.
Great. We just have a couple minutes left. So if anyone else has more questions, Leron says, I may have missed it, but does algae reduce inflammation? You spent considerable time speaking about the dangers of inflammation in humans. What is the connection to human health and reducing inflammation by directly or indirectly consuming this algae?
Or consuming other plants that have a lot of phytochemicals. We don't have a lot of evidence right now that eating either dead algae or live algae has an anti-inflammatory effect. Nor do we have a lot of data showing that eating crops that are grown with methods that increase the phytochemical levels, we don't have a lot of data showing that increases inflammation. But I'll tell you, those studies are being done, and they're measuring CRP, the marker of inflammation. I think we're going to get a lot of data over the next 2 or 3 years that happens. Right now, for us, we're not suggesting that people eat live algae. On the contrary, it's not approved for human use. You shouldn't be out drinking EnSoil algae. But there are questions about whether or not live algae reaching the gut, still alive, still producing the growth promoting hormones that have an effect on bacteria, as in the gut biome. There's a lot of interest in whether live algae in that situation will have a special benefit, possibly through its effect on the biome, which the gut biome can have an inflammatory or an anti-inflammatory profile, and they can actually measure whether or not the biome shifts to a more anti-inflammatory type. So yeah, a lot of data are going to be coming out with that.
And last question from Barry: has Brian Massard correlated any livestock mortality decreases or fertility increases due to the addition of EnSoil when growing their livestock feedstock? And I know you touched on that, George. The answer is yes to both. He's observed fewer winter deaths in the cattle, and also the increased conception rates.
Yeah, I'm not positive about I heard that somebody mentioned winter deaths. I'm not sure that happened. I don't know, but certainly the conception rates, the reverse of the failure of artificial insemination, are higher. So that's a pretty powerful biological signal of health.
So I'm just going to put up our next events for everyone to look at as we finish up. Our next webinar will be on the 18th, a week from today at 7 p.m. We're going to have Josh Toll from Rise Bio on to talk about the Roots to Shoots trial. This is a metagenomics trial that we did this year on corn across many farms across the country. So please join us for that. We will send out a recording of this webinar in the follow-up email. And then we have 2 upcoming info sessions that are sort of office hours, time to ask question. I'll give a short presentation on EnSoil Algae, March 26th at 3 Eastern and April 18th at 11 Eastern. As always, please reach out to us. We would love to connect with you. And thank you, Dr. Taylor, for your presentation tonight. And thank you all for being here.
Thank you.
Have a great night, everybody.